Welcome back on my Ossicum channel, Wisdom Teeth. This is the lesson on impacted upper third molars. When we talk about surgery, we always have to remind on the indications for extracting third molars. An interesting paper from the American Association of Oral and Maxillofacial Surgeons from 2016 tells us that impacted third molars are frequently associated with pathologies documented in literature. These pathologies may be caries, pericoronitis, root resorption, periodontitis, general infections, cysts, and tumors. The absence of symptoms associated with third molars often does not correspond to the absence of pathology. So, in case of the presence of the pathology, we have to choose for an accurate management of the pathology and of the extraction. But in case there are no pathologies, the decision to keep them and not to extract them involves a lifetime follow-up that has to be both clinical and radiological. When we're talking about upper wisdom teeth, we can decide and describe them with an anatomical position. So the position and the classification is according to the inclination of the tooth. And this is obviously a radiological implication. So the anatomical position may be of a vertical tooth versus a mesioangular tooth or towards a bucco-vestibular angulated tooth. Archer has described with his classification the types of angulation. We can have a mesioangular, a distioangular, a vertical, a horizontal, a linguoangular, or a buccoangular, depending on the inclination of the wisdom tooth, always in respect to the second molar. So if we look at the mesioangular angulation and we draw a line which is exactly across the second upper molar, we see that if we have an inclination towards the second molar, this is going to be a mesioangulated tooth. If we have a angulation which diverges from the second molar, then we are going to have a distoangulated tooth. The vertical is obviously something which is parallel to the second molar, and it is always a straightforward extraction. Another type of classification is on the depth of the impaction of the tooth. So we're going to have a class A impaction, which is where the line of the crown of the impacted upper third molar is in line with the occlusal plane of the upper second molar. And this is going to be an easy class A. We're going to have a class B when the crown of the impacted upper third molar is between the occlusal plane of the upper second molar and the CEJ line. A class C classification sees the crown of the upper third molar, which is in between the CEJ line of the second molar and the middle third of the upper molar roots. Whereas in the class D, which is the most impacted classification, the crown of the impacted third molar is going to be at or below the apical third of the upper second molar. Another classification is always in regard to the sinus floor and the maxillary sinus. So if we have that the sinus is positioned over the roots of the third molar, we're going to have a class 1 classification. Whereas if the sign touches the tips of the root, we're going to have a class 2 classification. If the sign comprises 1/3 of the roots, this means that the impaction is going to be a little bit more less straightforward, we're going to have a class 3 classification and so on. A class 4 classification comprises the sinus that involves 2/3 of the roots, and if we have a class 5 classification, the roots are going to reach the CJ of the tooth. Obviously, as we go from 1 to 5, we're going to have a major risk of oral sinus communication, and this is going to be taken in mind when we plan our surgery. For what regards the instrumentations, I send you to the specific lesson on the surgical instruments that I use in impacted teeth surgery that is present on the osteocom channel. But if we have to specify a couple of instruments that are a very useful instrumentation for the upper third molar extraction, we have to think about the pot elevator. This elevator has a particular shape. It has a concave shape. We have a left elevator and a right elevator, obviously facing the opposite side. And this is used to actually go around the crown of the tooth, entering the space in between the second molar and the third molar, and with a translational movement, we're going to push the tooth in the out buccal distal direction. And this is a very, very useful instrumentation. I've talked about the Langenbeck retractor in the normal situation of third molar impaction surgery. But if we're doing the upper third molars, then the long Langenbeck retractor is much more useful. This is because it not only helps you to retract your buccal flap, but having a longer shaft, it helps you to move out of the way the cheek in order to have a major visibility. When we talk about upper third molar surgery, we have to find the correct position. And we know that if the mouth of the patient is open, we're going to have an interference between the coronoid process of the mandible and the maxilla. And so the best position to perform upper third molar surgery is in a semi-closed position of the mouth. So what I tend to do is I tend to ask my patient to close the mouth, not completely, but slightly close, and to tilt the head in the opposite way of the tooth I am trying to extract. And using a long Langenbeck retractor, as we see in this image, we're going to have the correct axis, not having the lip in between, not having the interference of the coronoid process, and by having a good visibility. In terms of flaps and in terms of axis flaps, we have 3 different types of flaps. I personally prefer the first 2 flaps, and I usually don't perform the third flap, but is reported in books and in literature, and so I also cited it in this lesson. The first flap is the triangular flap. It is the flap that I usually use also in the lower impaction tooth surgery. And this has a sulcular incision of the second molar, and we can tend to decide if we want to stop at the second molar or if we go a little bit more medially on the first molar, and then we have a distal releasing incision towards the buccal distal aspect. We see here the image of this kind of flap. Whereas the trapezoidal flap obviously has a trapezoidal shape, and it has two releasing incision, a mesial releasing incision, which can be usually mesial to the second molar, but it also can be moved much more mesially on the first molar, and a distal releasing incision on the distal aspect of the second molar. This kind of flap gives us a major visibility, and it is used for deeper impaction. Always try not to make small flaps and then try to pull, because this can create some sufferance of your buccal soft tissues, because if we don't see a lot, we tend to pull a little bit stronger, we tend to pull a little bit harder, and this creates a reduction in the blood supply and so a sufferance in the soft tissue healing. This is an image of the trapezoidal flap. It exposes much more bone. It gives us the possibility to perform bone guttering and also tooth sectioning of the tooth, because the visibility is much wider, and there's a minor risk of creating lacerations or cutting of the soft tissues. The palatal flap is usually used for those teeth that are much more palatally impacted, and it has a sulcular incision on the palatal aspect of the second molar, and we have a releasing incision which goes towards the maxillary tuberosity. And it is used, as we said, for palatal-oriented teeth. We always have to be aware and careful on the palatine artery, which runs approximately towards the position of the second upper molar in the palatal aspect. For what concerns the bone guttering or ostectomy, the removal of bone, this can be performed with different instrumentation depending on the impaction, depending on the thickness of the surrounding buccal bone. We can use surgical curettes, we can use round bars on a straight handpiece, we can use piezoelectric inserts, or we can use magnetomagnetic technology. If we use rotating instruments, we know that we have to protect the soft tissues buccally in order to avoid any injury of the soft tissue. Be careful, we will see it in the complication that we can expose easily the Bichat fatty pad, which can slow our surgery due to the lack of visibility. And also be careful on traumatic heat burns of the soft tissue if we don't have a correct retraction and protection of the soft tissues. The odontotomy or tooth sectioning is performed if we have a particular divergence between the upper third molar roots, or if there is a deep impaction, mainly if the tooth is particularly angled, and so we don't have the correct space for the tooth to be extracted. Always be careful when we go and do the tooth sectioning in that area, which has a not very nice visibility, to be aware of where the roots of the second molar are, because we can risk a damage of the roots. After we have performed our tooth sectioning, then we perform our extraction using elevators and levers, and we then have to clear the alveolus, the extractive socket, with a surgical curette or with Lucas spoons, and then we can close our wound with a suture. You can use silk for zero sutures. I personally prefer to use reabsorbable sutures, because once we see our patient at a 1 week recall, we can have a little bit of soreness, a little bit of inflammation of the area, and it's not always easy to retract that area in order to remove the stitches. And so if we use a resorbable suture, we can leave the sutures in place and let them reabsorb naturally. What are the risks and complications of this kind of surgery? Well, I have brought to you a series of complications that are the most common in this kind of surgery. And the major complication is the fracture of the maxillary tuberosity. As we see in the picture, we know that the maxillary tuberosity can be binded to the tooth, to the ankylosed tooth, and also being a structure which is a little bit more brittle, it can break if we are not careful in the luxating procedures. So we can fracture the tuberosity, for example, if we have a complex anatomy of the root, or if we apply a force which is too strong in that area. It is always interesting and important to create a separation between the soft tissue in the distal palatal aspect, also because one of the other risks is that when we fracture the tuberosity, there is the possibility that the tuberosity remains attached to the soft tissue, and when we tend to apply a forceps or a tweezer to remove and extract the tooth, we can have the lesion of the soft tissue of the palatal aspect, and this can create a hemorrhage in the surgical site due to the fact that the tooth is attached to the tuberosity and the tuberosity is attached to the soft tissue. So always be careful to detach completely the soft tissues on the distal palatal aspect. Another kind of complication is the maxillary sinus floor perforation. We have seen in the classification that many times the roots of the upper third molar teeth are in connection with the maxillary sinus. Another possibility of treating the communication is either using a collagen sponge or a Rehrmann flap, or using the Bichat fatty pad that is sutured on the palatal aspect to close the communication. And this is a case where we have performed our extraction using a trapezoidal flap. We see here the phases of the extraction, and once the extraction is finished, we see that there is a communication by doing a Valsalva maneuver, so by asking the patient to blow air through the nose with a gauze, and we see the our mirror that becomes opaque, and so we know there is a communication. So in these cases, we have to close the communication, and we can go and find the Bichat fatty pad, and we separate it, and we create a reduction in tension in the fatty pad, and we can pull out the fatty pad from its anatomical region to be sutured on the palatal aspect. And then we can close the primary flap on the fatty pad. And this is a way of closing this kind of communications. We can see it better here in a major communication that was occurred after some teeth that were extracted in the upper maxilla, and we decided to do a Rehrmann flap associated with a Bichat fatty pad flap. So we see in the first image here that we have the fatty pad that has been found in the anatomical area. We see here that the fatty pad is elongated in order to be sutured in this image on the palatal aspect, and then after a releasing of the periosteum, we can elongate the primary flap in order to be closed as a second sheet on the underlying fatty pad flap. Another problem is the possibility of dislocating the upper third molars in the maxillary sinus. We see a case here where Federico has a 1.8 tooth and upper right third molar. We see here that the upper right third molar has been pushed in the maxillary sinus, and in order to remove the tooth and in order to remove the inflammation of the sinus membrane, we decide to go and extract the tooth. So we perform a larger trapezoidal flap in order to have a good bone exposure. We can see here that the bone is like very thin, and we see the underlying sinus membrane mucosa. We see it with this grayish kind of bluish bone color. We then decide to remove with a bone curette the small lining of the bone. Here we see it buccally. And then once we enter the sinus, we cut the sinus membrane in order to find the tooth which is embedded in the sinus area. And then we remove the upper third molar with a lever. In these cases, the difficulty is not in the fact that the tooth is particularly attached in its position, but the fact that the tooth can move in its position. So it's always better to ask the patient maybe to sleep the night before with a couple of pillows behind the head and to try to stay in a vertical position in order to avoid to incline the head and to have that the tooth goes and migrates in deeper areas of the maxillary sinus. And here we have the phases where we extract the tooth, we extract the mucosa that was attached to the tooth with this kind of cystic lesion, and then a closure of the primary wound with single stitches. One of the associated complications, as I said before, is the herniation of the Bichat fatty pad. So in this case, the fatty pad was not searched and used voluntarily, but it happened as an accident. And so we see the case where we're extracting a 1.8 tooth, and here we have the appearance of the fatty pad. The problem is that if we have an exposure of the fatty pad before we extract the tooth, one of the risks and one of the difficulties is that the visibility reduces, because the fatty pad tends to fill the space around the tooth, and so it's not easy to continue with the extraction. So in order to prevent the herniation of the Bichat fatty pad, we have to place a retractor on the buccal distal aspect, maybe using the large side of the Pritchard elevator, in order to avoid the entrance in the soft tissue. Another trick is to do a full thickness incision and always remain under the periosteum. So the periosteum has to be elevated completely. We don't have to do semi or partial thickness incisions, but we have to reach the bone with our surgical blade. Another risk is the incomplete extraction of the tooth, and this usually happens if we haven't done a correct planning of the extraction, and if we haven't studied with attention the anatomy of the roots. So in this case, the roots were left in its position. We perform a trapezoidal flap in order to expose the bone, and once we have exposed the bone, we perform a small amount of bone guttering, and then we can go and remove the residual roots that were left in the socket. And here is the root that was left, and here you see the stitches with 4.0 silk sutures. So how do we prevent these risks and complications? Well, the suggestions are with a careful and clinical and radiographic planning. So we have to study the X-rays and our patient specifically for that kind of surgery, and also evaluate the relationships with the nearby noble structures and morphology. So a correct planning can help us out in avoiding the risk and complications that I have just shown you. Let's look now at some clinical cases. We know, as we said before, that the anatomical position of these teeth are not so easy to be documented, and so we are not able to see exactly on the buccal side, because obviously we have the cheek that hides a little bit of the surgery. So let's look at some cases. This is Valentina, and we are extracting tooth 28. This tooth is disto-angulated, and we see it by looking at the vertical aspect of the second molar and at the direction of the third upper molar. We see that we don't see actually the roots, whereas we see them better in 1.8. And so we have to know that the roots may have a little bit of curvature. We see here in the CT scan how the roots and how the crown is positioned in contact with the second molar. And here we see part of the surgery. We see a retraction of the cheek with our Langenbeck retractor. The design of the flap is a trapezoidal flap. We have a good bone exposure, but we always struggle to see the distal part of the second molar. In this case, we created a small notch on the third molar in this area in order to push the tooth in the distal buccal direction. And here is the extracted tooth and the wound closure with 40 silk sutures. This 1.8 tooth is a mesio-inclined tooth. It doesn't have contact with the maxillary sinus, but the crown is apical to the CEJ, so it is a much more impacted tooth. We see here the images of the CT scan, and we see that there is not a lot of bone surrounding the tooth, the impacted tooth. We design a trapezoidal flap. This kind of flap is a particular flap because we didn't follow the intrasulcular sulcus between the 7th and the 6th tooth, but we designed a preservation, papilla flap preservation between 6 and 7. And here we have the elevation of the flap, and once we elevate the flap, we see that the tooth is directly in vision and we can see directly. And so with a forceps, it is not very easy, it's not very difficult to extract this kind of tooth, which was quite superficial. Once we have extracted the tooth, we check that the alveolus doesn't have any soft tissues, granulation tissue or inflammation tissue inside, and we can close the wound with a primary closure, in this case with a monofilament suture. And we see, as we saw in the radiograph, the comparison between the radiograph and the root, that the root wasn't particularly developed, and it was a quite straightforward extraction. In this case, we extract both 1.8 and 2.8 tooth. 1.8 is, I would say, a vertical tooth, whereas 2.8 is a mesio-angulated tooth. We see here a particular of the extraction. the triangular flap. In this case, there is actually almost no incision on the second molar. And once we create the space and we see the tooth with the insertion of our elevator, we create that distal angulation of the rotation of our lever in order to find the correct pathway for the extraction of the tooth. In this 2.8, we see that we performed a trapezoidal flap. We needed to see a little bit more. Once we elevate the flap, we see the 2.8 tooth coming out, and we need a little bit more space, so we do a little bit more bone guttering with a bar on a straight handpiece. Always remember to protect the shaft of the bar in this kind of surgery, because we want to avoid heat burns of the lip, which are very, very painful in the post-op period. And then once we created a little bit more space, we can enter with our elevator and we can do the distal buccal rotation of our movement in order to extract the third upper molar. We always help us out with a tweezer or with a clemmer in order to collect the tooth, and we check the integrity of the root apex to see that we have extracted completely the tooth, and then we close our flap, in this case with resorbable 4.0 stitches. This is a 1.8 extraction. We see some particulars of this CT scan. Some patients arrive to our referral, already with CT scan. And so we can see some particulars of these images that maybe we wouldn't have seen just with the OPG. We see that there is a little bit of distal inclination of the roots, an occlusal aspect, a buccal aspect, preclinical, pre-surgery. The design of the flap is a trapezoidal flap. I tend to use trapezoidal flap, as I told you, when I'm trying not to pull and push too much on the soft tissue in order to reduce reduction in vascularity of my flap. And so I tend to extend a little bit mesially the flap in order to see better and pull less. Once we have exposed our tooth, we create some bone guttering in order to expose a little bit more the roots of the tooth, and then we can luxate the tooth by pushing it in the distal buccal direction. And this is the moment when we extract the tooth. We see the roots, and we see particularly that what we saw in the CT scan was the divergence of the curvature of the root, as we see here in the clinical view, and the surgery is over. Another 1.8 mesioangulated tooth. In this case, we do a papilla preservation trapezoidal flap. The elevation of the flap, it's important to see that it is always a full thickness flap, and this always prevents any exposure of the Bisha fatty pad. And as I told you before, we also use some protection on the distal palatal aspect in order to detach the soft tissues from the tooth, also to reduce the risk of maxillary tuberosity fracture. And once we have detach the soft tissues from the tooth, then we can start to luxate the tooth. And so we enter the space in between the second molar and the third molar, and we tend to push the tooth outwards. This is a particular view of the alveolar socket and the closure by primary intention of our wound. So now we're going to see some live surgeries. We're going to see some live surgeries using rotating instrument and also using magnetomagnetic technology. So thank you for watching my upper third molar extraction lesson, and see you on my osteocomb channel.